Hi, I'm Dr. Dylan Seitz, and I'm a clinical neuropsychologist and a clinical instructor at CHI Emmanuel Neurological Institute and Creighton University School of Medicine here in Omaha. So objectives for today's presentation, I'd like you to be able to understand the incidence and impact of depression post-stroke, as well as identify the signs, symptoms, and subtypes of post-stroke depression. And finally, learn treatment techniques and behavioral management strategies that anyone can employ on the care team. In order to achieve those objectives, as a broad overview of what we'll discuss today, we'll go over some facts and figures related to depression and stroke, the pathophysiology and classification of stroke, so how does a stroke occur, what are the different types, the prevalence and course, how often does this occur, what does it look like over time, and then the specific symptom manifestations of post-stroke depression, as it can vary from more typical depression as well. So we'll also look at some various screening tools to identify depression in these patients. And then we'll discuss the appropriateness of when to refer or to get a psychiatric consultation or referral to behavioral health. Finally, some evidence-based treatment recommendations so that we can use the research to best support these patients. Some facts and figures, or why exactly is this important? Why are we discussing this today? Stroke is the number 5 cause of death and a leading cause of disability. And according to the American Stroke Association, up to 80% are preventable. So it's very important to know our own risk factors so that we can be on top of these things. Emotional and personality changes are also common following a stroke. In fact, a very robust meta-analysis reported that about 52% of patients that experience a stroke will also endorse depressive symptoms. Depression is also a treatable consequence of stroke. So not only is it common, but it's treatable, and it's also an independent risk factor of morbidity and mortality. So it is independently contributing to worsening the overall presentation, and therefore it's important to identify and to treat. Post-stroke depression is also linked to poorer outcomes relative to even strokes without depression. So again, it's this independent factor that really does worsen the overall trajectory for the patient. Stroke classification, so what exactly is a stroke and what are the kinds? A stroke is a blockage in the blood vessels, and it's these blood vessels that provide oxygen and nutrients to the brain so that it can perform optimally. Two large classes of strokes, one being a hemorrhagic stroke or an ischemic stroke, and they vary by how the clot occurs in the blood vessel. So if it's ischemic, there's an actual clot or blockage in the blood vessel, blocking those nutrients and oxygen. If it's hemorrhagic, the blockage is due to a rupture or a bleeding. Another term that often comes up when discussing stroke is a transient ischemic attack, or a TIA. This is a temporary stroke-like symptom in that there is a temporary clot, usually only lasts minutes to a few hours, but then it resolves. And so on subsequent neuroimaging or at hospitalization, there's no evidence of any tissue damage or any stroke at all on imaging. So for the purposes of this talk, we'll just be focusing on the hemorrhagic and the ischemic subtypes when discussing stroke, as that's also the one most commonly associated with depressive symptoms at follow-up. So potential causes and risk factors of stroke. Both ischemic and hemorrhagic stroke share common risk factors as well, but they also have risk factors that are unique to each subtype. They share risk factors such as chronic healthcare conditions like hypertension, diabetes, obstructive sleep apnea, and obesity, family history or even prior history of the transient ischemic attack, which, as I discussed earlier, that temporary syndrome, but it can serve as a warning sign or a red flag that someone is at increased risk for stroke. Relative to risk factors that are different between the two, an ischemic atherosclerosis, or this fatty buildup within the blood vessel, hypertension, high blood pressure, atrial fibrillation, or irregular or often rapid heartbeat, vasculitis, which can be an inflammation of the blood vessel, a rare condition, and then coagulopathy. In terms of an ischemic stroke where it's caused by this blockage, coagulopathy in this sense might mean that someone produces clots too easily. Whereas conversely for hemorrhagic, if you give the patient anticoagulants because it's based on bleeding, these medicines may not allow the clot to form properly. So it looks a little bit different. A hypertensive event is also a risk factor for hemorrhagic, similar to ischemic, and that the blood pressure can become so high that the vessel actually ruptures. Amyloid angiopathy refers to this buildup of a protein in the brain or the brain arteries called amyloid. It's also a risk factor for dementia. Aneurysm, or this bulging that occurs on the outside of the blood vessel, which can rupture. And then atriovenous malformation, which is disconnection or an abnormal wiring of someone's blood vessels, can also produce problems, can be congenital or something that you're born with, or even acquired in an injury. Substance use is also a risk factor, in particular the stimulant class, and even more specifically cocaine being the largest culprit. With depression, I think it's helpful to zoom out because depression can occur secondary to a medical event, like a stroke, but it can also occur idiopathically or in its own right. So when looking at depression more broadly, before we go into how it might manifest post-stroke, depression can really be hard to define because it's defined by its symptoms or the subjective experience of the patient. And it's often more stigmatized as well because for that exact reason, it can be more of an invisible illness. It's also stigmatized because these mood symptoms really do exist on a continuum from normal emotional experiences or affective experiences like routine sadness that we all experience time to time, the anxiety, nerves, etc. But it ranges from normal to more disordered or pathological. And when it gets to that disordered or pathological range, it's because of symptom duration, the type of symptomology specifically, the severity, and then how long those symptoms endure as well. Depression can be broken down into three larger categories: a reactive dysphoria, grief, and then the clinical depression or the major depression that's more classically documented in textbooks such as the Diagnostic and Statistic Manual of Psychiatric Disorders. So that's the most common when people think of depression or seeing a therapist. That's typically the diagnosis associated with that. Within reactive dysphoria and within grief, there's also that spectrum of continuum from normal, so reactions to everyday disappointments, stressors, to when it becomes more disordered, or something like an adjustment disorder. So the symptoms are severe, almost like an acute stress response. And that would be when it might warrant clinical attention versus just being a normal everyday reaction. Similar to grief, very intense, painful emotional reaction to losses in life, such as a divorce or the loss of a loved one. Again, a normal and important process of just being psychologically human and doing that grief work to get through it. However, when it prolongs past about a year, perhaps a couple of years, and the intensity doesn't go down, that could be considered something like complex bereavement disorder. So in the textbook definition, grief typically occurs very severely with these intense reactions for 6 months to about a year. Slightly less severe symptoms can ebb and flow, come in waves, as some may describe it, for the next 2 to 4 years. In complex bereavement, however, the intensity never abates and it continues on for a couple of years, and again, usually warrants treatment. Finally, then clinical depression, always considered disordered, just by definition, and impacts one's day-to-day functioning. How to differentiate these? I talked about the symptomology in general, as well as the severity, but what are the symptoms to look out for that might help the clinician or cue the clinician to know that this is not just typical or a normal reaction, that this might actually warrant treatment? Again, these subclinical forms, the normal grieving, reaction to environmental stressors. What that would share with clinical depression might be low mood, low daily energy level, crying spells, could occur in either. What makes clinical depression a bit different in terms of symptomology is that when it starts to degrade someone's self-esteem, self-critical, hopelessness, feelings of guilt, agitation or marked irritability, also a very common manifestation in men, but certainly not only in men. Early morning awakening is also common. Unlike anxiety, where someone may have difficulty initially falling asleep, depression, one tends to wake up early. A classic example is 1 or 2 hours before your alarm. Also can be associated with significant weight loss or actually weight gain, so appetite disturbance in general. Anhedonia, which means a loss of the ability to experience joy or pleasure in the things that used to provide you that same joy and pleasure, kind of this affective blunting. Impairment of functioning, by definition, to have clinical depression, it has to be impairing in a variety of contexts. For example, occupational, interpersonal. Flat affect as well, so very different from the crying spells and more severe forms of depression. there can be this flattened affect where they aren't really able to show or emote the full range of affect. Similarly, in more severe cases, you may also experience psychomotor slowing, a genuine motor slowing of the body as a result of the depression symptoms. So moving or narrowing into post-stroke depression more specifically, the literature is relatively new, but there is a decent body. But the consensus is that it's under-recognized, under-investigated, and undertreated. It's also associated with greater cognitive deficits than in patients that have strokes without depression. So again, this theme that depression is able to independently impact some of these other aspects that even just a stroke alone can provide, again, worsening the overall picture and potentially the overall outcome. Similarly, it's associated with poor functional outcome at discharge and at long-term follow-up, and with poor quality of life 1 year post-stroke. Potential hypothesis for this is that the depression symptoms may interfere with the patient's ability or motivation to follow up, complete homework assignments, whether it's occupational therapy, physical therapy, psychotherapy, may just have more difficulty being able to adhere to those. It can also impair attention, so it's not uncommon for appointments and things and reminders or just kind of slip through the cracks. Misclassification of post-stroke is also common, so while it's important to identify, it's also very difficult to differentiate, and that makes it rather difficult on clinicians. There's a significant overlap between stroke and depressive symptoms. For example, stroke symptoms can mimic depression in the sense that a stroke can produce psychomotor slowing or even disturbances in sleep. And then similarly, stroke symptoms can be mistaken for depression, so apathy, emotional lability, for example. In terms of protective factors, the research here is a bit more scarce, but one consistent finding is that social support from family did predict lower depressive symptoms at discharge. And the research also found that it wasn't just overall social support, but it was also when. So social support early on and as frequently as possible is associated with better outcomes. Post-stroke depression also has its own risk factors, such as cerebrovascular disease just at baseline, or white matter changes in the brain that can be due to chronic healthcare conditions like diabetes, like hypertension. Lacunar infarcts, which are very small lesions in the deep gray matter structures or deep white matter, deep gray matter structures being the basal ganglia or the thalamus. And I think this is an interesting point to highlight because these are very neuroanatomical in nature, these risk factors, for example, meaning that this kind of depression doesn't appear to just be reactionary to all the changes associated with stroke, whether it be changes in cognition, physical changes, but there appears to be something at the neurochemistry level or neuroanatomically that also sets the stage for patients to experience depression just because of the stroke or vascular insult itself. A greater sense of uncontrollability, so the sense of low self-efficacy or low self-agency. If the patient believes they don't have it within themselves to make change, or that I'm never going to get better, it doesn't matter, this is my new life, those kinds of cognitions tend to be associated or predict depression in the subacute phase. Just at baseline, also higher levels of neuroticism are associated with going on to develop post-stroke depression. When it comes to post-stroke depression, location matters. So where in the brain did the stroke occur? If it's left-sided, depression is most common, usually greater than 50% across studies, and I'll go into more detail about why that may be in the next slides. It tends to present initially within days to weeks, and then peak about 3 to 6 months. So that's usually when it's at its worst. And then the symptoms gradually resolve over time, even without treatment. Of course, with treatment, the window is more narrow. However, if the stroke occurs on the right side, it can look quite different. It can start with this initial flattening, where the patient may be indifferent to their own deficits, or perhaps lack insider awareness into the changes that have occurred. They may also struggle with picking up emotional cues of others, social gestures, for example, even their tone of voice, sarcasm, and they may even present themselves as monotone or having difficulty emoting or expressing a full range of affect. Interestingly though, although it starts with this initial flattening, it then tends to progress to a more severe depression over time, and it gets worse. And this is particularly relevant to my work in neuropsychology, as I often will see patients who were in their recovery trajectory. And because of the worsening depression, they think the stroke isn't healing, they think they're getting worse. They often go to the ED multiple times to get serial CT scans just to make sure. So again, just being able to provide psychoeducation about how this may progress can save a lot of unnecessary health care, as well as just ease the anxiety for the patient. But it does tend to get worse, even 1 to 2 years post the stroke event itself. Even more specifically with where the stroke occurs, if it's on the left side, but it's more anterior towards the front of the brain, depression is far more common. And that's believed to be because the left prefrontal cortex of the brain, so the most forward aspect of the left side, underlies positive emotional valence, or the ability to assign a positivity to an internal or subjective experience, so how we experience joy. I once worked with a patient who had a very strategic injury to this area and truly was unable to experience happiness again. And so I think in one sense it's fascinating that just one aspect of the brain can produce something like that, but it's also quite tragic in that that's such an important part of someone's quality of life. And so helping patients understand that these aspects may be outside of their control can also be helpful. In a right posterior lesion, so right side of the brain moving towards the back, that is when depressive symptoms are linked to that 1 to 2 years. So depending on where it is in the right side of the brain may predict that not only that worsening, but for how long it might be worsening for. In general, if the stroke occurs in the frontal lobe, regardless of depression, you can expect or maybe experience behavior or personality changes. The frontal lobe is responsible for executive functioning or problem solving, multitasking, cognitive flexibility. Another way to think about cognitive flexibility is being able to change gears on a bike. Kind of you're doing something, getting off that path. Patients can get stuck or perseverate or even have to act compulsively. So it can almost produce this OCD or obsessive compulsive disorder syndrome. It's also, the frontal lobe is also important for being able to put on the brakes and inhibit, self-monitor ourselves, have empathy and perspective take. So sometimes these patients can go from being rather caring, and then they'll tell me in my office, I don't even know this person anymore. They don't seem to care about anybody else. They don't seem to care about their own personal hygiene. And of course then can be devastating for the patient and their family. It's also associated with changes in sleep and libido or some of the other vegetative symptoms of depression. When the stroke occurs in the corticobulbar pathway, or the pathway that connects the brain to the brain stem, or more specifically the motor nuclei, there's a phenomenon called pseudobulbar affect that can occur. And it can be thought of as a disconnection syndrome in which there's a release of motor control from the brain or the brain's perception. So this can look like sudden laughter or even crying, and most commonly it is crying, and it's usually without an emotional trigger. So that could look like laughing inappropriately at a funeral, or even crying when something joyous or happy happens. Of course, this can be quite troubling to family members as it can occur in inappropriate settings or in outside social settings, and the person may be unaware that the patient had any kind of brain injury. So now that we've discussed post-stroke depression, how exactly do we assess it or identify it in our patients? Really two main ways, the first being a semi-structured interview, the next being a clinician or patient-rated scale, and so these are often self-report scales. The semi-structured interview is the gold standard for diagnosis. However, it's not always feasible in hospital or post-acute care settings. It's lengthy, it requires training. Some examples include the structured clinical interview for the DSM or the SCID, or the Hamilton Depression Rating Scale. Even clinician-rated scales can be a bit cumbersome to the care team or require some training, so most of the literature recommends using self-report screeners or patient-rated scales. They're quicker, they allow for grading or being able to quantitatively monitor the patient's symptoms over time. So are their depressive symptoms responding to interventions? Should we look at a medication review, consider adjunct psychotherapy? It just helps more objectively monitor their depressive symptoms. And because of that, they're brief and can be completed by just about anybody on the care team, and scoring is usually available online. As an example of a semi-structured interview, this one's public domain, so I was able to include a couple examples of it. As you can see here, there's different symptom clusters: depressed mood, feelings of guilt, and then some of them they expand as different core symptoms related to depressed mood, such as sadness, helplessness, worthlessness. The clinician is trained to ask those questions and elicit those responses, as well as grade their response from 0 to 4, depending on the quality of their response or the content. And that can take some training to figure out because it is a bit arbitrary to some degree. They can take about 45 minutes to an hour, so are rather lengthy. However, they are the most diagnostically accurate, so about 87% correctly identify depression in those cases. And that's using a cutoff score of greater than or equal to 17. However, in a screening context, we want to make sure we're not missing the condition of interest. So we want to increase the sensitivity of the test, even if that means we are incorrectly identifying people, just to make sure that we're watching it and can provide the services if needed, or at least get them to an outpatient setting where it can be more comprehensively evaluated. For that, the cutoff is recommended at right about 12 or greater. Because post-stroke depression is common and it should always be evaluated in that context, as I said, the screening tools are brief. They have adequate sensitivity and specificity in identifying depression, and they can be administered by anyone, and those are certainly the advantages. But there are some cons as well. It can be problematic to decide which tool to use. And that really is a problem with the construct validity, meaning are we measuring what we're supposed to be measuring? Post-stroke depression, across some studies, is argued that it might be a completely separate clinical entity from major depression. The issue with that is all of these screeners are made from the diagnostic manual's definition of depression. So if they're slightly different, are we actually identifying what we're supposed to be identifying? The other issue is some of the symptom overlap. So because some of the depression screeners ask about somatic symptoms, strokes are known to cause such symptoms, and so there can be some confusion related to that as well. What's owed to the stroke? What's owed to the depression? Clinical settings also, if this patient is currently hospitalized, for example, and the screener is asking about sleep disturbance or appetite disturbance, all of those can be influenced by their environment because usually these are outpatient. The patient's considering their own home context when answering these questions. Similarly, a lot of these screeners ask the patient to look back about 2 weeks. Might not be as much of a negative in a post-acute setting where it usually has been some time since the injury, but in more acute or subacute phases, that may predate the stroke, and so they're not actually thinking of the correct time when they're answering the questions. Finally, patients with aphasia or other cognitive consequences from the stroke may not be able to comprehend some of these screeners as well, or may need materials written to them. So there's just some other things to think about when choosing which tool. These are the screening tools consistently validated by research. A few are public domain or free, available for anyone, and you can find the scoring. That would be the Geriatric Depression Scale or the PHQ-9. The ones that are paid but also excellent tools would be the Beck Depression Inventory, the Hospital Anxiety and Depression Scale. And I say they're excellent because they all maintain adequate sensitivity and specificity in identifying depression across studies. So for screening tools that may be more appropriate for this population, my overall favorite would be the Geriatric Depression Scale, particularly the short form. There is a 30 question version as well. However, the 15 is shown in research to be just as good, if not better, at identifying depression, and it's a bit easier, quicker to administer. It doesn't require any training. The questions are fairly straightforward. It's public domain and free. And I also like that it uses a yes or no format, which just makes it easier for the patient to answer. In some of the questionnaires, they have to use a Likert scale, where they have multiple different options to keep in mind. While that's usually okay if the patient has it in front of them, they can fill it out. In some cases of aphasia or cognitive impairment, the examiner might have to read the screener to the patient. So now everyone's having to keep all these different options in mind, or they have to keep repeating the same key to use, and it just takes a lot longer. So I like the yes or no format as well. So this can be administered to anyone ages 60 or older. And while most strokes do occur after the age of 65, we also know there's a sizable portion of patients that experience strokes younger, and so it's also important to keep that in mind to potentially use a different tool in that case, such as the PHQ-9, which is another public domain screener meant for younger adults. So questions to ask the patient, these should be included regardless, but especially if the patient is unable to complete a screener. These are some questions that can just help get at mood or the patient's symptom experience. So questions like, have you noticed any personality or behavior changes in yourself? Do you feel like yourself? I find this to be a good segue into talking about mood, as most people can readily identify personality or behavioral changes, and oftentimes what they say will often come up as sadness or anxiety, and it's just a nice segue into some sometimes more difficult topics to discuss. Similarly to that, I'll phrase anxiety and depression as low mood, high worry, how have your spirits been? I just find that it can be less stigmatizing, and particularly in older adults as well. They may not have this word in their vernacular lexicon or as associated with a more extreme stigma. So this just can level the playing field and allow them to openly discuss their emotional experience. To get at things like apathy or initiation, can ask, is it more difficult to get up and go? Do the things that usually excite you or bring you joy still bring you that same sense of joy and excitement? Gets at anhedonia. And then changes in sleep, daily energy level. These last two here, the anhedonia or the vegetative symptoms, can be more difficult depending on the setting. As I said earlier, if they're in the hospital, they may not have had the opportunity to re-engage with the activities that brought them joy or excitement. So they may just not be able to fully know that yet if they're still hospitalized or in any kind of acute care setting. So when to refer to the behavioral health team or consider consult by a psychiatrist. Really, if any of these aspects have a positive screen, so the screening tools, if able to be given, behavioral observations by the clinician, so what's the clinician seeing? Are they seeing crying spells? Are they seeing flat affect? Difficulty engaging with them? Collateral information, if available, is the family concerned? What are they noticing? And that's often a great source to be able to determine change in personality, as of course they had that experience and knew this person before the insult to their brain. Referral to neuropsychology can also be beneficial. So as a neuropsychologist, we're able to produce a comprehensive profile of a patient's cognitive strengths and weaknesses, but we also can evaluate their emotional functioning. While we know the mechanism, so it's the stroke that led to these strengths and weaknesses, it still is important to document them as it can help guide further treatment or cognitive rehabilitation. For example, if a patient's verbal memory is intact, yet their visual memory was impaired by the stroke, you can utilize verbal skills to try to compensate for those other weaknesses. Similarly, when you identify a weakness, let's say the patient's memory was impaired on neuropsychological testing, that might help you inform how the family needs to interact or how they might need to provide extra supports or care. For example, if there is a memory problem, having them have reminders, checking that their medications are being taken, all of those essential IADLs that have risk for more adverse outcomes, wanting to make sure that they are following through, helping them schedule appointments. If the neuropsych exam comes up with dysexecutive functions, so problems with organizing or planning, then it might be helpful to help the patient organize the pill box. So even if they can remember to take the medications, they might have trouble organizing their week because of that dysfunction. The neuropsych exam can also help establish a baseline, ideally in the post-acute phase. As we know, a stroke over about a year is the course of natural healing, and that's on a negatively accelerated curve, meaning we expect the bulk of the healing within that year, but the most of the healing would come 1 to 3 months. We'd expect slightly less healing, 3 to 6 months, and so forth until it plateaus to a new baseline. So ideally, an evaluation in the subacute phase, and then 12 to 18 months to help monitor that healing and establish a new baseline, answer questions about capacity, return to work, etc. So for treatment techniques that can be used by anyone on the care team, usually beginning with psychoeducation, reassurance to the patient's family, being able to separate volition, or what the patient is actually in control of, versus what their brain is having more difficulty with now. So these personality changes, of course, can be quite apparent and disruptive to the family, but allowing them to know it's not that they don't care, that they're not showing up in the same way that they do. It's not something that they are having any active control over. That can be a helpful place. Of course, still very difficult, but at least a helpful place as an inroad for empathy. It can also be helpful to talk about the recovery course and prognosis. I've had many patients come to my office and they don't know what to expect. They're left to their own devices, and how long should this be taking? Is this normal? And can just cause a lot of undue anxiety or even worsen depression in some cases. Another just quick psychoeducation bit as an example for intervention with pseudobulbar affect, as I mentioned, that disproportionate crying or laughter. A way to terminate that rather quickly is to just ask a neutral question, something like, what color are your shoes? It provides that distraction, and then that stimulus doesn't usually have an emotional valence, so they quickly snap out of it. Whereas I see a lot of patients and their families try to counter it, tell them everything's okay, try to soothe them, which may work with somebody that has that control or that connection in their brain, but with pseudobulbar affect, they don't have that ability, so it's often more helpful to just distract. Another thing I recommend for care teams is ongoing monitoring, so being able to screen for depression multiple times throughout using those objective screeners. Again, that can just help guide further intervention. Is the medication working? Do we need to add therapy, etc.? Similar to that, research supports both pharmacological intervention and behavioral intervention for these patients. There's some mixed debate in the research about which one is more beneficial, but the overall consensus in any review paper is that a patient can benefit from both. With medications, ultimately, consultation with a psychiatrist is recommended. This is because of the symptom overlap. So for example, apathy, which can be a feature of both stroke and depression, if you give a patient an SSRI that has apathy not due to depression, it can worsen in some cases. Similarly, the symptoms produced by the stroke, apathy, impulsivity, can also respond to other medications, and a psychiatrist is best suited to be able to handle that referral. That being said, I often recommend that someone starts with their primary care provider to initiate mental health medication. That can just be due to long wait times, and most are generally very comfortable prescribing something like sertraline that has low risk for any kind of contraindication for the patient medically. Beyond medicines, the psychotherapy or behavioral techniques, there are some evidence-based protocols provided in the literature. And these are very regimented, streamlined approaches that anyone can use and adopt. They follow a very specific timeline and include materials. One common one out of Mitchell et al. 2009 is Living Well with Stroke. And in this evidence-based protocol, they use the American Stroke Association materials about recovery from stroke and even about depression and how that might look. They also use a medication diary to just start some behavioral changes and building some good habits for adherence to treatment. And they get reminder calls if they don't send that in, because they're required to send the journal in prior to attending the session. This can also be time to let the family know if this isn't going well, for example. So then afterwards, the family knows to check in with the patient more often if this is a consistent difficulty they're having with this protocol. The patient is taught to view the depressive symptoms as observable and modifiable behaviors that are initiated and then maintained by person-environment interactions. In other words, depression can be really cruel in that the very things that make it better, engaging with people, being social, being active, are the very things that depression make very difficult to do for the patient. So in this way, it gives more self-agency or empowers the patient that this is something that I can control. So it's called behavioral activation. If we increase the positive experiences, pro-social engagement, putting the depression in a backpack is another metaphor often used, in that it's difficult, it's not going to feel good, but over time, if you keep doing it, it gets less heavy. And that's ultimately one way out of that kind of depressive cycle that can be so cruel and difficult for patients. Another example of an evidence-based protocol that utilizes a similar methodology and relies on behavioral activation is CALM out of Thomas et al. 2012. And these programs are able to be looked up through the article and available to adapt. Beyond an evidence-based protocol, there also are ways from the research just to adapt the clinical interaction for these patients. A lot of these recommendations come out of brain injury or cognitive rehabilitation groups, but certainly they're also suitable for those that have experienced a stroke. For psychotherapy or really any therapy, physical therapy, occupational therapy, They recommend shorter sessions, but more frequently. So instead of maybe meeting for once for an hour, it'd be 30 to 45 minutes twice a week. This helps manage fatigue, but also supports that session carryover, kind of that cumulative building of what you're working on. Providing written summaries, repetition can also be helpful, particularly if there are any cognitive difficulties. A multimodal presentation, so as I discussed earlier, when finding out the patient's strengths or weaknesses, harnessing those strengths to be able to create associations between new concepts or interventions that they're learning. External aids, if there is a memory problem, providing the patient with an audio recording of the session, a summary, again, trying to build that cumulative process that's so important in any therapy, but also very much relies on memory. Metaphors and analogies are often recommended over trying to educate the patient on a more abstract concept. So the example I used earlier with cognitive flexibility, if that's where the impairment is, describing it as having difficulty changing gears on a bike, or you're driving on a road and your wheel's stuck and you can't take a U-turn or turn left. It's just difficult to get out of that lane. Things like that can just help the patient make more sense of themselves and these new changes, as this wasn't present before. A central folder to organize handouts or homework can also be helpful, and the family usually can assist with this. You can also harness technology such as text messages to help provide reminders, help patients adhere to treatment recommendations, involving significant others. Not only does this provide more social support, but also allows the patient to increase their understanding and reflection of the activity. So with today's presentation, we've covered stroke, depression, and how depression may uniquely manifest in patients that have experienced a stroke. Gone over some screening tools that anyone can use on the care team to help identify depression in those patients, as well as some helpful assessment and treatment techniques. This is important, again, as depression is an independent factor that can worsen the overall prognosis and outcome for these patients, and is often overlooked and not identified.